thank you for the opportunity to present some of the work that we're actually going to be doing in relation to the COVID-19 pandemic. So my name is Shelby Yamamoto. I'm an assistant professor in the School of Public Health. And normally I focus on environmental issues, so climate change and air pollution are two of the areas that I focus on. But as an epidemiologist, I do have the opportunity sometimes to engage in and work outside of these fields. And so this is what I'm going to be presenting today as part of this talk. So specifically, the work that we're going to be doing in relation to the COVID-19 pandemic is going to be focused on some of the potential psychosocial impacts of the pandemic in our pregnant women and healthcare providers in Anhui, China. I just wanted to briefly introduce the rest of the team before I move on to talking about some of the details about the project. So we have Professor Keith Dobson, who is a clinical psychologist out of the University of Calgary. We have Professor and nurse Shahiroz Premji, who is within the School of Nursing at York University. We have on our China side, on the China team, we have Professor Dr. Fengbao Tao, who is out of the Anhui Medical University, and also a researcher, Dr. Beibei Zhu, who's also out of the Anhui Medical University as well. We have on our team Professor and biostatistician Gian Jangri, who is also in the School of Public Health here at the University of Alberta. And we're joined by a student who has been working with us in the original project, the larger project, Jessica Yiling Li, who will hopefully graduate this spring and will continue on working on this project with us for the next year. And Shanchan Shao, who is again with our team in China, also based at the Anhui Medical University. And lastly, our MSc student, Chunhui Tian, who is completing her master's in the School of Public Health, also at the University of Alberta. So this is a photo that was taken of some of our team members at a meeting that we had last year. So just to provide a bit of background information about the setting and about for the context of the study. So this study is being conducted in the Anhui province in China, and to date, the Anhui province has reported about 990 confirmed cases of the COVID-19 and 6 deaths, unfortunately. As I had mentioned, we are focusing on the potential psychosocial impacts of the COVID-19 pandemic. And there is evidence to suggest that stress, anxiety, and depression are important considerations during these kinds of events. And so when we were looking in the literature, we saw evidence from studies that had been conducted during the SARS outbreak in 2003. So obviously the healthcare providers are expected to be and are heavily affected by these kinds of issues. And so we want to be able to study this in our healthcare providers as well. So, and unfortunately, there are some longer term effects associated with these kind of events. So there was a study that was done in healthcare providers in a Toronto hospital during the 2003 SARS outbreak, and what they found is that healthcare providers reported higher levels of burnout, psychological distress, and post-traumatic stress 13 to 26 months after the SARS outbreak. So again, there's evidence to suggest even some of these longer-term impacts that need to be studied and investigated and considered. Pregnant women is a group in which there hasn't been a whole lot of studies done yet with regards to these kinds of events. We do have evidence from other sort of disasters, such as the Fort McMurray wildfires and also the Quebec ice storms. And so there is evidence to suggest that pregnant women can be vulnerable to these particular events and this could be a particularly vulnerable time for this group. So specifically in relation to the COVID-19 pandemic, pregnant women might be worried, for example, about their own health or the health of their fetus and family members, might have economic considerations that they are grappling with as well. They might not have access to the same sort of services or the same level of services that they might have had before the pandemic was declared, because a lot of those resources are being funneled now into obviously handling the COVID pandemic. They might be worried about having to deliver in a hospital where patients are being treated for COVID-19. So there are a lot of considerations that pregnant women might be dealing with during this period of time, and so this is why one of the reasons why we wanted to focus on this particular group. And unfortunately, we do have evidence to suggest that psychosocial stress during pregnancy can impact birth outcomes adversely. So things like a higher risk of preterm birth, as an example. So just some other information about mental health in China in general. So the direct annual economic cost of mental illness in China is about 89 billion as of 2013 data. The antenatal and postnatal depression prevalence widely varies depending on where you are in the country and the services available. So, and can range from between 6 to 28%. Unfortunately, mental health services have not kept pace with this demand and with this burden. And so in China, there's only about 1 bed per 100,000 persons available for mental health services as compared to 4.4 beds per 100,000 population when you compare to international statistics. So again, something that's a little bit concerning. So the COVID-19 project is actually embedded within a larger project that we have ongoing at the moment in Anhui, China, which is the screening and management of perinatal depression within primary care. And so this is a project that's really aimed at ramping up or developing, both ramping up and developing perinatal mental health services for pregnant women and postnatal women. And so some of our aims are, for example, to assess depression in pregnant women and also to be able to develop a larger perinatal depression and screening management program that we can implement within some of the health systems in China. So right now we have piloted a lot of the work in one city, in Nanshan City, but we will also be scaling it up to 3 other cities to include Hefei, Bangbu, and Fuyang, all within the Anhui province of China. So a part of this is also assessing not only the depression in pregnant women, but also the PDSM program implementation and how this works and what that looks like. And so this has involved a lot of work talking with not only the women, potential participants in this program, but also healthcare providers and key stakeholders within the health systems within the cities that we're implementing this in. We're also rolling out an internet-based cognitive behavior therapy program for pregnant women to address depression within this group. So we have developed the ICBT program, and which is called Mom's Good Mood, which is a series of 11 modules that can be done over a period of time. It can be accessed online, so women don't have to come into the clinic to be able to access the intervention. So they can start and stop and pick up where they left off at their convenience. So with this ICBT program, we are going to be evaluating the impact, acceptability, and adherence of this particular intervention. And as part of the larger project, we will also be engaging in assessing the reach, efficacy, adoption, implementation, and maintenance of the larger PDSM program as a whole, and how this can be worked into the health system rather than just being sort of a one-off project. And obviously, we want to know something about how the impact of the program over the longer term as well. So I just wanted to give you a quick run through about how this works with the participants that we have included in the pilot study. So the participants have been invited to a baseline screening with their primary healthcare provider. And part of this baseline screening has involved screening for depression. And so we have using the Edinburgh Postnatal Depression Scale, which is a very common tool that is used to assess depression in pregnant women. And it is a series of 10 questions, so it's very short, that are scored from 0 to 3 and then summed for the entire survey. And so the scores can give some indication of the levels of potential levels of depression in women who are screened. And the cutoffs are not necessarily hard and fast. They do vary between different studies and between different populations, with some choosing lower cutoffs, some choosing higher cutoffs. So for this particular study, we have actually chosen 4 different sort of cut points. And so, for example, with women who score with EPDS scores below 9, what we're doing with that particular group is just following up in terms of subsequent screenings with them. So all participants in the study will be followed up for 6 times, so including the baseline screening. Those women who have EPDS scores between 9 and 11 will be offered the intervention, which is also known as Mom's Good Mood, and the intervention program, and they will also be screened and followed up again. So for another 5 times after the baseline screening. Those with EPDS scores between 12 and 13 will be offered not only the Mom's Good Mood intervention, but will be also offered psychosocial counseling, which is covered by the grant, and we will also follow up with them as well. And those that are potentially at higher risk will, so those with scores of EPDS scores greater than 14, greater than or equal to 14, will be offered the Mom's Good Mood, the counseling, but also will be referred for psychiatric assistance as well. And this also goes for women who express any sort of suicidal ideation as well. So the COVID-19 project is really following up with some of these objectives longitudinally. So the first 2 objectives, for example, if we're looking at the depression we're looking at depression in pregnant women and PDSM program implementation during the pandemic, the COVID-19 pandemic, and also after the pandemic. So we had originally anticipated just conducting the pilot study and moving on to scaling up this work into the other cities that I was talking about. But because of this particular event, we thought it was important to be able to assess how this has affected the EPDS scores of participants and new participants that we are currently still enrolling, and will continue to enroll even after the pandemic has ended. So we get a sense of how the depression levels, if they have changed, and what those changes look like before, during, and after the pandemic. We also want to get a sense of how the postnatal depression screening management program acceptability and adherence, if it has changed, and how it has changed over this period of time as well, which we will be assessing not only just quantitatively, but also qualitatively through focus group discussions, and also through more now through interviews, one-on-one interviews. We also will evaluate the impact and acceptability and adherence to the ICBT intervention, the Mom's Good Mood, and in depression and for depression in pregnant women. And again, we'll use some longitudinal approaches. So we will be using a generalized estimating equation approach with ICBT as a predictor of EPDS scores. And again, we will be also conducting interviews to assess usefulness, acceptability, and adherence, not only among our participants, but also among the healthcare providers as well, who are administering or who are screening the women. The additional objectives that we have that are built on to this project, in addition to the larger parent project that we have going on, is to investigate some of the potential adverse birth outcomes in relation to this event. So we're exploring preterm birth, small for gestational age, and low birth weight as the adverse birth outcomes that we will be examining. We will obtain this data from the health records with consent, of course, from the women who are participating, and we'll also do some investigations in terms of potential effect modifications. So does this relationship look different by trimester of exposure? So does it make a difference if women are exposed during the first, second, or third trimester, or the duration of the exposure that they have had? And in order to more fully and more richly sort of explore the experiences of pregnant women during this period of time, we will also be conducting one-on-one interviews, likely through telephone and through other social media means, to obtain their personal experiences. So, what kind of stressors were they encountering? What sort of anxieties or other concerns were they worried about? If they were concerned about these things, what kind of access to care did they have? Did they feel that there were certain things or needs that weren't being met, and so on and so forth? So again, we're going to explore these more from using qualitative methods. And lastly, of course, we thought it's important to be able to assess the impact this is having on healthcare providers. And so we're going to use a couple of tools to assess healthcare provider anxiety. So the first is the state trait anxiety inventory, which is very commonly used um, to assess both state and trait anxiety. For this particular project, we're going to be focused more on the state anxiety, which is attached more to the occurrence of specific events, such as the COVID-19 pandemic. We will also be using the GAD-7 tool, which is the Generalized Anxiety Disorder tool, again, which will give us an indication of the potential generalized anxiety in relation to the COVID-19 pandemic. And again, to more fully explore the challenges and experiences of our healthcare providers in this region, we will be conducting one-on-one interviews uh, with healthcare providers, and also exploring healthcare provision, which we thought was an important topic to explore, because even though a lot of the healthcare services and provision is going to be geared towards obviously to handling the COVID-19 pandemic, other healthcare needs don't necessarily stop during this period of time, and so we wanted to assess what the healthcare provision looks like in relation to other services, so specifically perinatal health services. And so we'll be assessing through our interviews with our healthcare providers that has looked like, and what sort of changes have obviously have been occurring in relation to because of the COVID-19 pandemic. So some of the research impacts that we're anticipating are information or data or findings really about the mitigation of potential psychosocial issues during events such as this. So not just waiting to introduce interventions after the event has occurred, but what does that look like during the event? How does that compare to the introduction of the event, the intervention before the event and after the event? So I think this is going to be really important information to share now, especially not just with China, but also with other countries and other health authorities, as research and healthcare provision and resources are changing throughout the COVID pandemic. And obviously, a big part of our work is helping to inform clinical and public health responses. So again, all the findings and the data that we are generating in the study are going to be shared as widely as possible, because we want to be able to support decisions, not only just from a clinical perspective, but from other public health response perspectives in helping make helping them make these kinds of decisions and the allocation of resources as part of this response. We also are hoping to confront some of the stigma around psychosocial issues in China. So mental health issues are still fairly highly stigmatized in this part of the world, and so we're hoping through this work that we can start to break down some of these barriers in terms of the stigma, in terms of access to mental health services, and to actually mainstream this care into health systems in China. And we're hoping this research will also generate some findings about the importance of offering psychosocial support during emergencies. So as I had mentioned before, a lot of the healthcare resources are being dedicated, obviously, to containing and treating and detecting the virus during this pandemic. But it's important to remember that there are other services and other potential healthcare impacts that might need support during these emergencies as well. And one of these is the potential for psychosocial support for not only the healthcare providers, but for other groups as well. So patients, people who are quarantined, and so on and so forth. And lastly, we're hoping that this study will shed some light into the provision of healthcare services that are outside of those dedicated towards the COVID-19 pandemic. So what does this look like, and how important is it to maintain these kinds of services, and what can be scaled back or what needs to be maintained? And so hopefully we'll gain some insight around health service provision in this kind of context as well, which we can share. So I'd just like to end by acknowledging some really important people that have and are involved in this work. So obviously a huge thank you and a shout out to our healthcare providers who are on the front line, and to the participants of our study as well, who generously donated their time and are participating in the study. We'd also like to acknowledge the funding from the Canadian Institutes of Health Research and the National Natural Science Foundation of China, who funded the larger parent project, the GACD 322 project, and also the Canadian Institutes of Health Research, who funded the current COVID-19 project that I just presented on. So thank you for allowing me to present some of the work that we're going to be engaging on with this COVID-19 pandemic. And I do welcome any suggestions or any comments that you have on this work. So I know I'm not able to engage with you live, but if you want to send me an email, my email is on the first slide of this presentation. And so I would welcome any of you who want to reach out. So thank you very much.